Hi, I'm Karen Calechman, the National Community Manager for DES Action, and we're honored to have here with us today Dr. Gary M. Levine, who is Director of Memorial Care Breast Centers in California, and a radiologist and a breast screening specialist. And I get lots of questions about breast screenings on our resource line. So we thought it would be wonderful to interview Dr. today. And also we have an article if you have collected your voice newsletters, he's quoted in the spring 2015 voice edition. As I said, I'm the National Community Manager for DES Action USA. And some of you who are online today are not DES exposed. So you may have asked yourself, what is DES? DES was a synthetic estrogen that was created by a British researcher in 1938. He worked for the British government, and therefore his formula was never patented. Many pharmaceutical companies got a hold of the formula and created DES as a drug to prevent miscarriage. It was created under many brand names, but initially the British researcher had created it to assist with symptoms of perimenopause and menopause. It was never meant to be used with pregnant women. Unfortunately, there was in 1947 who had the incorrect hypothesis that it would prevent miscarriage. Much later, they were proven to be wrong. But meanwhile, for many years, from about 1938 to 1971, and in some cases after that time, DES was given, it was called the wonder drug, and it was given to pregnant women as an anti-miscarriage. So if any woman was having a problem with pregnancy, most likely she was given DES. And then in 1953, a researcher at University of Chicago was lying in hospital, did a study because he thought that DES wasn't going to prevent miscarriage. And in the end, his study proved that it did not. And it was not useful for preventing miscarriage. Unfortunately, his study was kind of brushed under the rug. The pharmaceutical companies used previous studies to sell their product. And in fact, even later, DES was actually proven to cause a higher miscarriage rate. So the biggest, most important 1971, Dr. Arthur Herbst at Boston's Mass General Hospital had a cluster of young women with a rare cancer, clear cell adenocarcinoma of the vagina. And why? Because this kind of cancer usually shows in postmenopausal women. One of the mothers said, could it be this drug I took when I was pregnant? They followed up on that. And sure enough, every one of the mothers whose daughters had this cancer had taken DES. So it was in the international, and the FDA did not take DES off the market because it was used for other purposes, but they urged doctors not to prescribe it to pregnant women and that it was dangerous. And they further notified doctors and said, please go through your records, see if you have any patients who took DES, and please warn them that they may need to be checked out. So that started 40 years of research. And some of the impacts of DES exposure for both the mothers and the daughters in utero are a somewhat higher risk of breast cancer. And of course, last month was Breast Cancer Awareness. And we're a little bit late, but we wanted to interview Dr. Levine to encourage you to get your screenings, but we want you to get the right one. The only other thing I wanted to let you know is DES Action has been an organization for 40 years, since 1978. It was started by Pat Cody and other DES mothers. And we advocate, identify, empower, and educate the DES population and the general public. We're not for profit. We don't take any money from pharmaceutical companies, and we are member supported. So please, if you have an interest or you're a part of the DES population, you can go to our website, www.desaction.org, and you can join. It's only $40 a year. We have many, many benefits to membership. You can see that on our website. But again, we are celebrating our 40th anniversary as an organization. And part of this celebration is interviewing once a month a thought leader in the industry. So I want to welcome Dr. Levine and just tell you a little bit about his background. He's the medical director of Memorial Care Centers. His undergraduate degree is from Tufts University with special honors in biological research, medical degree from Albany Medical College, and then he completed a residency in diagnostic radiology at the University of California, Irvine. And then went on to specialize and do a fellowship in training in breast imaging in Sweden under the renowned mammographer, Dr. Laszlo Tabar. Then Dr. Levine returned to Orange County and became the medical director of Memorial Care Breast. So we are very, very lucky because Dr. Levine speaks internationally and nationally, and we're thrilled that he's taken the time. Thank you so much to be here with us today.
Thank you for having me.
So I have some questions, and as I can see on the screen, people are tuning in. And I do want to mention that this video will be posted on our website within about 24 hours. So if you don't catch it live today, or we don't get to your questions today, you can watch the video on our website, probably by tomorrow night. And if we don't get to your questions today, I will check any questions tomorrow that have been unanswered and forward them to your answer and send it to you via email or Facebook. Okay. So first question, can you describe the different kinds of screenings?
Breast screenings. So we're talking specifically about screening for breast cancer. And generally we do this with mammography, which is a form of the X-ray that's specifically designed to look at the breast tissue in order to detect the breast cancer before it can be felt on a physical exam. So the idea behind breast cancer screening is early detection. We always hear about that. That means this concept of finding breast cancer before it becomes palpable while it's still very small and easily curable. Again, the gold standard for breast cancer screening is mammography, this examination, but we do have other imaging technologies, including ultrasound, MRI, even so-called PET scanning, which is a type of nuclear scanning of the breast. And sometimes those additional studies are used in addition to the mammography.
Okay. So DES exposed women, both the mothers and daughters, have the mothers about 30% higher risk, and the daughters, it's been measured in one of the studies about 1.7 or 1.8, and now the latest study shows 1.07. So DES daughters who are kind of worried about this, what's the best kind of screening for them?
Sure. So all women routine mammographic screening. Recommend that's done a year, but at least every other year in order to detect this early breast cancer if it were to occur. A DES woman or a daughter of a DES mother should also have the routine mammographic screening, and depending on additional risk factors that particular have, they may benefit from additional what we call adjuvant screening, screening on top of routine mammography.
So the average woman can have dense breast tissue, but it seems to be more common in DES daughters. I know that even myself, I got a letter when I had happened to have a 3D ultrasound mammogram. And it said your mammogram tissue is dense breast tissue is common, not abnormal. However, dense breast tissue can make it harder to evaluate the results of your mammogram and may also be associated with an increased risk of breast cancer. This information about the results of your mammogram is given to you to raise your awareness and to inform your conversations with your doctor. Together, you can decide which screening options are right for you. So when anyone, whether she's DS exposed or not, receives this kind of letter, what's the best way to proceed, and what kind of screening should they have?
So there's two factors that we're talking about here in women that have dense breast tissue. And again, it's not an unusual thing. About 40% of women have dense breast tissue. But there are two factors that apply. One is we've found that dense breast tissue have an increased risk of developing breast cancer as opposed to a woman with fatty replaced breast tissue. But in addition to that, and maybe more importantly, that a woman with dense breast cancer, it's much harder to find the breast cancer on a routine mammogram. So again, two factors. They're more likely to get breast cancer, and it's harder to find the breast cancer if it does occur on a routine, what we call two-dimensional mammogram. And so about 10 years ago now, a little less than that, a new type of mammography was developed, what's called 3D mammography. You just mentioned that you had this, and this is the type of mammogram that's best for women with dense breast tissue because it allows us to inspect the breast tissue 1 millimeter slice thick at a time. So you can actually see through that dense breast tissue, potentially finding a breast cancer that otherwise would not have been.
Okay. So if I understood you correctly, you said that also women with dense breast tissue have a higher risk of breast cancer?
That's right.
Do you know what causes that?
So it's a phenomenon that's actually been described in the literature for many years, but it wasn't until an activist in Connecticut who had dense breast tissue and their breast cancer was not on a routine 2D mammogram. She wanted to know not why, and spurred the legislature in Connecticut to approve what's called the adjuvant ultrasound screening of women with dense breasts. Ultrasound is a technology that's good for women with dense breast tissue. It's not affected by the dense breast tissue, and you can find the cancer readily. So the concept of this adjuvant screening on top of routine X-ray mammography was developed. Technique of adjuvant screening has now spread really across the country to the point where the federal government requires places that perform mammography to inform patients if they have dense breast tissue. This note that you just read that you received is mandated by the federal government. We have to inform women with dense breast tissue that they have dense breast tissue, that affects the accuracy of 2D mammography, and that there are other technologies that can be applied, and that they should discuss that with their physician. So routinely in women with dense breast tissue, we now again, this better form of mammography that allows us to through the dense breast tissue. And in those women that have increased risk, the 3D mammography plus another imaging modality, whether it be ultrasound or MRI.
Okay. Yeah, I think even I was confused. I was thinking ultrasound and the 3D mammography was the same, but it's not.
Not the same, not at all.
Okay. So you're saying, in addition to this 3D mammography, you can have an ultrasound as well.
Correct. Ultrasound, again, is not affected by dense breast tissue, so it's a good screening technology. In addition, doesn't replace the X-ray, because again, the X-ray mammography can still find things that are not on the ultrasound, and vice versa. So we use them together for screening women with dense breast tissue. Now, in women that are high risk, and the definition of high risk is you have a greater than 20% likelihood of developing breast cancer sometime during your lifetime. In those women, we actually use MRI in addition to the mammography for screening. MRI is our most sensitive study. It's the best study for finding breast cancer in women with dense breast tissue, but it's really only utilized for those women that are of the highest risk. And the reason for that is simply a cost basis. MRI is a very expensive technology, and so insurance companies will generally only approve its use for women with greater than 20% lifetime risk.
Thank you. So I think you already answered this. How often should a DES woman with dense breasts be screened? And you said every 1 to 2 years?
Yeah, so we recommend yearly mammographic screening. So every year you're having a screening mammogram, and we compare that with your previous mammograms to assess whether there's any interval change. Again, in this subset of patients that are high risk, greater than 20% likelihood of developing breast cancer, we actually use a regimen where they're having a mammogram and an MRI each year, and those exams are staggered by 6 months. So for example, they have a mammogram every January, and every July they would have an MRI. So we're seeing them twice a year, but they have each study once a year.
Okay. And our technology director is saying, could you scooch a little closer? She wants to see your
I don't want to scare anybody.
Neither one of us like being on camera, but we are trying to educate. I had a DES daughter who does not have breast tissue. That's just the same every year.
And should be having mammography once a year. Again, the women with dense breasts or the women with a higher risk, we may have supplemental studies on top of that. But again, it's important to remember that 75% of women that are diagnosed with breast cancer have no previous family history. The idea that, well, nobody in my family has ever gotten breast cancer, we hear this a lot. I don't have to worry about it. That's really a fallacy, and it's something that we try to educate women on regularly. Again, 75 history, they have no specific risk factors, so all women should be screened.
Thank you. Let me see what else we have here. Oh, and you and I were just discussing before we started the information on gadolinium contrast, because I did have an experience where one of Dr. Levine's colleagues suggested I get an MRI, both contrast and non-contrast. And it was approved by my insurance company, so I was very lucky. I went in to have the MRI, and there was a full-page disclaimer that didn't look like other disclaimers I had had. And I read it more carefully, and it said, this kind of dye can be deposited in your brain, in your muscles, in your bones. It could take up to a year for your body to get rid of it. And for the normal person who doesn't have kidney disease and doesn't have sensitivities to dye, it'll be fine. I happen to have sensitivity to prior MRIs and things that I've had in my past. So I was nervous and I didn't sign it. So can you kind of explain a little bit about that? Is that the only kind of dye that's used in a breast MRI? What is the situation with gadolinium contrast dyes?
Yeah, I'm happy to. So MRI is a technology. It stands for magnetic resonance imaging technology that it's been around for decades, since at least the 1980s. And one of the really nice things about MR is it was felt to be extremely safe. There was no known harmful effect of MRI. Again, it uses magnetic fields to create an image of the body, whether it be the breast or elsewhere. And again, one of the benefits was it had no harmful effects, as opposed to other imaging studies like X-ray, where we know radiation exposure has some harmful effect. Mammography, it's extremely low dose and it's felt to be harmless, but there is always this risk-benefit ratio that we have to keep in mind for any study. So MRI for decades has been felt to be completely harmless, great technology. The contrast dye that we use, gadolinium, which is a metal, and years ago now, it was discovered in a patient that was having repetitive MRIs many times within the course of 1 year. They found a small amount of gadolinium deposited in a specific area of the brain. Wow, look, it's there. Not that any harm from that gadolinium, but once that was started to wonder, is this gadolinium that's deposited in people that are having repetitive MRIs going to cause problems in the future? And so now when you go involves a contrast injection, that patient is informed that gadolinium has been shown to collect in the muscles and brains of individuals that are having repetitive MRI. And you should be aware of this. Again, nobody has found any connection with any harm or disease from that deposited gadolinium, but it's the first time that we're starting to be aware of it. And so, again, what it boils down to is always keeping in mind that the benefit that can be obtained versus the potential harm from the study itself.
Are there any alternatives to that kind of dye?
So gadolinium is the only dye used presently routinely with MR, although they're being done to find alternatives. For breast MRI, we need to use the contrast. That's what highlights the tumor. So it's not like you can do the MRI and not utilize the gadolinium. The gadolinium is needed. What that gadolinium does is it collects at the site of the tumor, and it appears as essentially a light bulb saying, hey, there's an issue in this location in the breast. Let's go look at that area, try to find out what's the problem.
So there's really a benefit to having an MRI without contrast dye?
Not for a cancer study.
Okay.
So for women that have implants that are having trouble with their implants, we'll do MRI without contrast. But if you're looking specifically for cancer, that contrast is vital. That's what allows us to find the cancer.
Okay. Thank you. And so as I said, I was lucky that my insurance company approved it. But you had mentioned before that it's less and less that they're approving these kinds of things.
Yeah, the MRI, understandably, is very expensive technology. These machines cost millions of dollars, and so the charge to the insurance company is significant. And so the insurance companies have, over time, gotten very right about the women that they'll approve for the breast MRI. And generally, what it entails is a woman that has that greater than 20% lifetime risk. This is specific for breast cancer screening. If they don't hit that threshold of having the 20% lifetime risk, generally the insurance companies will not approve the breast MRI. Now, breast MRI is used for other use. In women that are newly diagnosed with breast cancer, we use the MRI to assess the extent of the and to check the patient's lymph nodes. And there are several other scenarios where we will use breast MRI. But if we're specifically talking about breast cancer screening, it's generally limited to those women that have a greater than 20% lifetime risk.
Thank you. What about monthly self-breast examinations? Are they still advised for all women and particularly DAS exposed women?
So this is a great one that's being debated quite a bit. The truth is that for decades we've been recommending that women have yearly mammography and that they also do monthly and yearly clinical breast examination by their physician. That's still a good, but the issue is that many women don't really know how to do a proper self-breast examination, and so they're feeling lumps in the breast and they're confused at whether this is an important lump, not an important lump, and it tends to be a confusing issue. What I would recommend is that women learn how to do a self-breast examination from their physician or their nurse practitioner, and then perform it monthly at the same time of the month, every month. Learn what's normal for them, and then anything that develops will be a change from that normal template, and they should bring that to the primary care physician.
Thank you. So the risk of breast cancer for DES daughters, does it seem to fluctuate or change?
So this is general for all women, whether your daughter of DES patients. The incidence of breast cancer rises. You're more likely to be diagnosed with 60s and 70s than you are when you're 40s. Doesn't mean it doesn't happen for younger women, but the incidence is greater as you age. So one of the primary risk factors for breast cancer is, number one, being a woman, number two, advancing age. So one of the caveats is that a younger woman that gets breast cancer, for example, in their 40s, those breast cancers tend to be more aggressive forms of breast cancer. So it's vitally important that we diagnose the breast cancer in these women. So I really disagree with these recommendations that say that women can consider delaying their screening until they're 50, because I can tell you personally, the diagnoses I make in women in their 40s are the toughest cases that we see. These are women with usually, again, more aggressive cancers that are faster growing and tend to metastasize earlier. And there are also women that tend to have young children. And so these are particularly devastating diagnoses. Young children at home, aggressive tumor, a really treacherous diagnosis. And one thing I always like to point out is that breast cancer, although a very common, is also among the most curable cancers that occur. If we find breast cancer early, generally it can be cured with a very small operation, or any surgery at all. We're using non-surgical techniques to kill very, so women don't even have to go to the operating. And I think that will become more and more prevalent in the future. The concept is early detection. We find breast early when it's small and confined to the breast. It's generally extremely easy to cure, and a woman with the rest of their life in a very healthy manner. We find breast cancer late. It's a much more complex and devastating diagnosis.
So we're mentioning age 40, and it just occurred to me, I didn't say anything about DES grandchildren. And since DES is an endocrine disruptor, so my understanding of that is it changed the way the genes communicate and turn off and turn on. So to protect you against things, to stop growth, start certain growth of cells and so forth and so on. Our grandchildren generation now are between the ages of about 20-ish and 40. I talked to a DES granddaughter who was in like 42 the other day. We do not know if the breast cancer risk has been passed down to that third generation. We have not found evidence of it yet, but I think it's a good idea for women age 40 to get mammograms in their screenings. And DES was given for so many years that there's a wide range of age range of mothers, daughters, granddaughters, grandsons, and sons. And although sons and grandsons' impact have not been breast cancers or chest cancers, there are other impacts on the sons and grandsons, and I didn't want to leave that out. And you can go to the website to find what those impacts are. Okay, so as studies continue, we talked about 2 studies that came out last year. One of the studies kind of said that perhaps the breast cancer risk for DES daughters was like a co-founding, not a collateral sort of risk, not a direct link. And they weren't quite sure about it, but they said because DES daughters don't oftentimes, unfortunately, have gynecological anomalies or can't have children, infertile, that makes them a higher risk for breast cancer. Now there's a study that just came out that we're going to be reporting on in one of our next newsletters that talks about estrogen metabolism in DES daughters and how it may be metabolized differently. So as all this comes out, obviously our population is afraid and gets scared. But I think the main point that we're trying to make is that if you have your mammograms yearly and you're saying every woman as she ages has a higher risk, and you weigh the risks versus the benefits, that's kind of the best precautions that you can take. And interesting, once you read the study, the newest one about the estrogen metabolism, kind of what I would be interested to hear, maybe through email, what you.
I'd be happy to. There are many medications that have been linked to cancer, whether it's a causal effect, the medication itself causes the cancer, or whether there's other mechanisms that occur down the line. And I think likely we'll never know. But we do know that there is an increased risk in DES exposed patients, and that they should be especially about their screening. I think that's the message.
What would you suggest if somebody's a DES exposed woman and for her to ask her doctor or discuss with her doctor as far as breast screenings? Will a doctor generally recommend, because they're DES, an extra level of screening, or how do they kind of start the conversation? I found I get a lot of calls about that. People don't know what kinds of questions to ask.
Yeah, so it's going to be variable, Karen. To be honest, there's going to be primary care clinicians that may not be aware of the link between DES exposure and cancer. I think, as in all cases, it's important that a woman be very proactive in their own health care. So they take them prompting their clinician, are you aware that there's an increased risk of breast cancer in women like myself? I think that would be a good idea.
Okay. And you touched upon it before, but I loved the analogy that you gave in the newsletter, because some women are worried about the amount of radiation, and I think you said something about it was minuscule, like flying from LA to New York.
Yeah, so women worry about the harmful effects of X-rays associated with mammography. Listen, it's not a comfortable procedure. Done properly, it shouldn't hurt, but no woman looks forward to coming in for their mammogram every year. We're aware of that. But one of the reasons that women use to avoid having mammography is this concept that they're getting X-ray exposure and that it's dangerous. A lot of studies have been done addressing this. And what I can tell you is that consensus is that the minimal amount of X-ray that a woman is exposed to during mammography is far outweighed by the benefit of potentially finding an early cancer. And if somebody asks me how much X-ray exposure, the best way that I can communicate an analogy. So the amount of irradiation exposure from a screening mammogram is equivalent to the amount of solar X-ray exposure, solar radiation exposure that a woman gets by getting on a plane in LA. Nobody worries about their exposure from taking an airplane flight. And I think it's a good way to present just the small amount of X-ray that's exposed, that a woman is exposed to from having a mammogram. Somebody can hang their hat on exactly what that means.
Right. It puts it in perspective. I guess we're coming up to kind of the last question here. So I have had DES daughters call and say I was just, and I ask them, oftentimes they say, don't even ask me, I got tested for BRCA1, BRCA2. Many times they tell me, nobody in my family had this, or somebody far removed, a cousin. Should they be checked for the BRCA1 and 2 mutation?
Probably not.
Okay.
So women that have BRCA1 or 2 gene mutation generally have a very strong family history, and it's first degree relatives, so it's sometimes aunts and grandparents as well, and it's very prevalent in the family. So a woman that has a distant cousin that got breast cancer and that's it is extremely unlikely gene. So what we generally do is we do a cursory history of a patient that's coming in for a screening mammogram, provides their family history. And if there is a sense that there may be higher than average risk, those patients are then invited to meet with our genetic counselor. The genetic counselor goes deeper into their family history and actually calculates an accurate risk of gene mutation. If appropriate, then either blood or a little bit of a swab from their cheek is taken, and we can do that BRCA analysis. So I think to answer your question, a woman that doesn't have a significant family history is really unlikely to have what's called genetic breast cancer in their family.
Yeah, I think the confusing thing to some DS daughters, I had a case the other day where the woman called me. She did not have breast cancer, but both her mother, who was a DES mother, and her sister, who was another DES daughter. So the mother took it with both pregnancies. Mm-hmm. Both of them had breast cancer, whether that was attributed to DES exposure or a mutated gene. So I just said you might want to consider talking to your doctor about testing.
Any woman whose mother had BRCA gene positivity, they should be evaluated because you want to know if that gene mutation has been passed down to yourself. That's very important because if you have a BRCA gene mutation, your likelihood of getting breast cancer or ovarian cancer, which they're linked on the same gene, are very, very high, and those patients are treated differently than an average risk woman.
Okay. Thank you. Well, unless you wanted to say something else, we have time for questions, and I have our friend in the background there writing anything. Were there any questions? Okay. As we just about hit our half-hour mark, and I don't want to hold Dr. Levine any longer than he has. So again, people can watch this video on our website within about 24 hours. Usually by tomorrow night we'll have it posted. You could also come back to our Facebook page and look at the video. And if questions for Dr. Levine, you can always post them on our Facebook page, or you can email me, Karen, Karen, at desaction.org. That's Karen, desaction.org, with a question you might have, and I can forward it to Dr. Levine, and we'll get your answer for you.
Happy to do
Thank you so much.
Thank you for having me.
All right. Stay well, everybody. And as always, we tell you that, to live your best life, eat right, get exercise, get your sleep, drink enough water, and take